The next speaker will be Dr. Ramon Garcia-Sanz from the University of Salamanca, and he will update us on the diagnostics, symptoms and treatment criteria for patients with Waldenstrom's. Dr. Garcia-Sanz.
Okay. Good morning to everybody. Thank you very much for being here today to allows us to share some worries and some information with you. Well, I'm working in several monoclonal gammopathies, and especially in Waldenstrom's macroglobulinemia, which is one of my main topics. Excuse me. Now, maybe now it's better. Okay, this is my first time to speak for patients. This is very unusual in Spain, so I hope you will be not too strict with me. Okay. So I'm going to speak about definition and diagnosis of Waldenstrom's macroglobulinemia. I always put this slide when I have some speeches, and the first thing is to remember that Waldenstrom's is not very frequent. It's about 6% of all monoclonal gammopathies, which means around 1 patient with Waldenstrom's per 10 patients with myeloma. This is something that you should know when you go to the physician. In my country, this means this incidence, about 3 cases per year and per million persons, is about 140 patients per year, which in Europe, in all Europe, is around 2,500 people as new. And is typically presented in the advanced age. Most series I have seen usually put the median age about 65, 66. In my country is more older. For 71 is always in my series, and always with a predominance in males, 2 to 1 more or less. And it's very important to know that the natural history is an indolent disorder. The median survival for our series that we published in 2001 is a bit different to the current survival, because at that moment the criteria for diagnosis was not exactly the same as now. But at that moment we published a series in 2001 with a median survival of 11 years. So the number of patients, if you multiply the incidence and the duration of the survival of these patients, could be that 25,000, 30,000 people is now living in Europe with Waldenstrom's macroglobulinemia, so not so rare. And the other important point is that as an indolent disorder, many patients die not for Waldenstrom's, die due to other problems, because at the age of 71, we expected to have some other problems. And maybe now is even the proportion of patients dying of other problems and not of Waldenstrom's is higher. Yesterday, in this meeting, the group reviewed their series, and 50% of the patients died due to other causes. And finally, we always try to put some additional interest in the disorder because of the therapeutic efficacy. Physicians have to know well the disorder, because when we treat patients, most of therapies provide a 60, 70, 90% of responses in our patients. And the last topic is that it's a very interesting disorder from the biological point of view, because the tumor cell is just in between the lymphocyte of the chronic lymphocytic leukemia, and in the other side is the plasma cell that is typical of the multiple myeloma. So this disorder and the cell that produces it provides a lot of ideas for the other 2 disorders that are more frequent. Okay, this is the cell that we can say that they're responsible of the disorder, especially. I don't have a pointer. Especially the one that it's in the very left side.
Somebody stole the point already.
Oh yeah, it's here. Oh, it's this one, which is that shares the morphology typical between a mature lymphocyte, the typical lymphocyte that we can see in the blood of everybody when we look at the microscope, and the other is the plasma cell, that is a much rarer cell that we can see almost only in the bone marrow and at a very low frequency. And the second important thing in the Waldenström's is this, that probably many of you know, the monoclonal peak. This is an electrophoresis of the proteins that we all have in the plasma. And in this side, you can see this monoclonal peak that is not present in normal population, but is present in people with monoclonal gammopathies, as Waldenström's macroglobulinemia is. And in the right side, you can see the immunofixation. That is the second test that we have to do in the laboratory with the plasma of the patients to see these two bands, one identifying the IgM and the other one identifying the restriction of the light chain. So with these two simple tests, we can diagnose many cases of Waldenström. But we have had the two aspects: this infiltrating cell and the monoclonal component. And this is how we define Waldenström's macroglobulinemia since 2003 in a meeting like this one that was held in Athens. And it's a rare and uncommon lymphoproliferative disorder characterized primarily by bone marrow infiltration, these cells that I showed, and the monoclonal component gammopathy, the IgM peak that I have also shown. The two things are required. And when the pathologist evaluate the bone marrow that we send him, they have to refer us a report saying that the cells that are infiltrating the bone marrow construct a lymphoplasmacytic lymphoma. So, lymphoplasmacytic lymphoma infiltrating the bone marrow and monoclonal component, IgM. Well, when we look at these disorders, we always have to distinguish between these four quite closely related disorders. One is symptomatic Waldenström's macroglobulinemia. The second one is the asymptomatic Waldenström's macroglobulinemia. The third one is this, the IgM monoclonal gammopathy of uncertain significance, the IgM-MGAS. And a fourth group of related disorders that we will see in a minute. It is very important to distinguish them because all of them have the monoclonal component, have the easy part of the disorder. All of them have IgM monoclonal component. But they are very different in the second part. Bone marrow infiltration is present only in the Waldenström's macroglobulinemia, while it is not present in MGAS and IgM-related disorders. So the cell component is not present in these two disorders, while it is present in the Waldenström's macroglobulinemia. And it's also important to distinguish between symptomatic and asymptomatic. Symptoms derived from the monoclonal component, from the tumor infiltration, or from both. But they are not present ever in asymptomatic Waldenström's macroglobulinemia. And finally, obviously, in IgM-MGAS, we never see any symptom. And in the IgM-related disorders, it's a very difficult group that we always see, because we can see the monoclonal component. Obviously, we don't see the bone marrow infiltration. We don't see symptoms due to tumor infiltration, because there is no tumor, there are no cells infiltrating any tissue. But we have symptoms due to IgM. So this small group of disorders were called IgM-related disorders, and they included several types: amyloidosis, peripheral neuropathy, skin lesions due to the monoclonal component, but in the absence of any tumor infiltration in the bone marrow or outside the bone marrow. So all this means that when we want to diagnose a patient with some of these disorders, we have to do a bone biopsy. So this is the reason of why the physician, your hematologist or your oncologist have to ask for the bone marrow biopsy to correctly diagnose this disorder. And about the symptoms, it's very important to distinguish very well between symptomatic and asymptomatic disease because of this. Because, well, this is a survival curve. I don't know if you are familiar with a survival curve. This is the survival that is expected for the global population, for the general population at the same age and sex of a series of patients with Waldenström's macroglobulinemia in green. And as you can see, as the time is going by, 5, 10, 15, 20, 25 years, people is dying because of life. So, and this is what we expected in a global population. This work was done in France, so this is what the expected mortality for the population over 65, over 60, over 70 in France. And in yellow, you can see in the right part that the survival curve of the patients with symptomatic Waldenström's macroglobulinemia from people that was diagnosed in the 70s or in the 80s, people is dying before the global population. So it's the mortality is increased in Waldenström's macroglobulinemia patients with symptomatic disease respect to the global population. But on the left side of the picture, you can see that in case of asymptomatic patients, the survival is quite similar and not a statistically significant difference between the global population. So very important to distinguish between symptomatic and asymptomatic disease. Even more, symptomatic patients have to be treated, asymptomatic patients have to be followed, not treated. Well, something about the biology of the disease, what we do with the cells that we take out from the patients. One of the most important things is, apart from the microscope that I already showed, is immunophenotypical evaluation. Here you can see the cells that are represented by dots in the upper part of the picture, and the dots are separated from the vertical axis to the right, and the more to the right, the highest the expression of the marker that we see in the top, immunoglobulin, surface immunoglobulin, CD19, CD20, CD22, CD25. And here you can see that there are 3 types of populations. In cyan, B cells, Waldenström's macroglobulinemia lymphocytes. In dark blue, normal B precursors, or in red, normal B mature lymphocytes. And you can see that using all markers, the populations can be clearly separated. We can distinguish very well between dots that are cyan or that are red or that are dark blue, distinguishing very well between them. So it's a very nice tool that helps us in the diagnosis. And also it can provide us information on these markers. Maybe you can recognize very well this marker, CD20 marker. All the cells are very bright, very on the right. So this is a target that we can use for therapy. And at this moment we have a very active drug against this marker, which is rituximab. Rituximab is anti-CD20. So it's logical that this monoclonal antibody targets these cells and can help in the elimination of these cells. And we are doing this kind of studies for many other antigens at this moment in order to see or to discover new markers that can be targets for therapy with new monoclonal antibodies. And sometimes it helps in very difficult situations like this one. We can distinguish it very well for the diagnosis. In this case, in red is a Waldenström's macroglobulinemia respect to the what we could expect in another lymphomas that are quite closely related with Waldenström's. In yellow is the position where we could expect to be cells from a marginal zone lymphoma. So also a very useful tool for helping us in the diagnosis, in the distinction between different disorders that can have different management. From the cytogenetics, in the past we were doing a lot of cytogenetic studies because there were some alterations like deletion 6q, another abnormalities, deletion 13, 17. Okay, we were evaluating them a lot because they were present in 40% of the patients, the rest in 5% of the patients, but they were not very helpful in the final diagnosis, and they have all been hidden by the discovery of the MYD88 mutation, which is a mutation that was discovered in many genes, but in this case in the MYD88 gene at the 265 amino acid, in which one amino acid is changed, and you've seen changed by a proline that was discovered by the Boston group 4 years ago. And the most important thing is that although other mutations can be found at a lower frequency, at 20–25%, MYD88 was present in 87% of the patients in the first series. Other groups, like the Spanish group, reproduced the results. In our series is a bit lower, 82% of the patients. But in all around the world, now that the prevalence of this mutation is in 90% of all Waldenström's macroglobulinemia patients, and probably it will be more frequent in the future, since the tendency is that patients without the mutation will be diagnosed of other things, and the patients with the mutation will be diagnosed as Waldenström's patients. Other mutations are less frequent. Maybe the second one, more frequent, is the CXCR4 mutation, since it is present in 35%, 40% of the patients. So it is not useful for diagnosis, but it could be useful in the near future for guiding the therapy, since CXCR4 mutation seems to have a different response to the current therapies. This is something that we are now investigating. It's not yet mature for defining the therapy in the near future, but it's something that we are now evaluating very carefully. The clinical picture that you probably know better than me is usually with a presentation that most frequently is in form of fatigue. Is the most frequent. Around 40 to 50% of the patients have fatigue. That is usually due to anemia, or a reduction in the hemoglobin level, or hyperviscosity, because the protein that's present in the serum is of high viscosity, so it produces sometimes a syndrome called hyperviscosity syndrome, in which anemia is part of them. Other possibilities are lymphadenopathy, lymph nodes that can be evident, but it's less frequent, 25% of the patients. B symptoms, 23% of the patients. Bleeding, 1/4 of the patients. The rest are less frequent, neurological symptoms. And sometimes, when we published this series, at this moment the criteria of diagnosis were different. At this moment we were discovering patients with asymptomatic disorder in 27% of the patients with high amounts of IgM. So sometimes it can be discovered as a symptomatic situation, usually because there is an evaluation due to other things, due to other problems that require a proteinogram, and then we see the monoclonal component. Globally, the clinical characteristics can be divided between tumor growth, tissue infiltrations, and paraprotein effects. The symptoms due to tumor growth can be seen in this slide. One is bone marrow dysfunction, usually in form of anemia, which is, as I said, one of the most frequent symptoms. 20% of the patients have lymphocytosis in the hemogram that we do in the patient, in the blood analysis. We can see this lymphocytosis, and less frequent is neutropenia, increasing the frequency of infections, or thrombocytopenia, risk of bleeding, but they are less frequent as bone marrow dysfunction. The it can also be seen due to tumor growth in the secondary lymphoid tumors, especially in form of lymph nodes that can be touched. In about, I said, 20% of the patients, and less frequent is hepatic and spleen enlargement that can also be seen, although not frequently at diagnosis. And finally, we can see any organ of the body that can be infiltrated by the cells, and we can have problems at the pleura, lungs, kidney, skin, any part of the body. Although, fortunately, this is less frequent. And related to the M component, we can see some other problems. As I said, the hyperviscosity syndrome, when the monoclonal component has some special physicochemical characteristics, or when it is very high, we can have this syndrome that is characterized mainly by neurological problems, especially reduction in the consciousness level, tendency to sleep, stupor, maybe even coma, cardiac problems, especially patients who have problems before the diagnosis of the Waldenström's. They can have a disbalance in this problem. The onset of a cardiac insufficiency, especially in very elderly people. And the other problem can be hemorrhagic problems, especially in the mucosas, especially epistaxis and in the mouth. Cryoglobulinemia and cryogagglutininemia is not frequent in Spain because these are related with low temperature, but maybe more frequent in areas like this. But they are not also frequent, but it's something that we always have to evaluate as physicians. And sometimes there is also the antibody, the monoclonal component is an antibody, can have some interference with several systems. And it's very important to recognize them, because it is clear a relationship between the disease and the complications. Sometimes it's not easy, but when this antibody interference exists, it's more clear to evaluate this. They can provide, again, problems at the neurological level, renal level, etc., that I insist are not frequent, but have to be recognized if they appear. So these are, and this slide is another reminder of all the symptoms. I remember the most frequent is anemia, and the second most frequent is hyperviscosity syndrome and B symptoms as a problem associated with this disorder. Well, what about the prognosis? The prognosis at this moment is not the same for all patients. There are several aspects that are associated with a worse prognosis. In 2009, the group published a series of almost 600 patients in which we evaluated many different aspects. And we saw that there were 7 that are listed in this slide related with a poor prognosis. Age beyond 65, high beta-2 microglobulin, low, hemoglobin below 11.5, platelets less than 1,000 per microliter, and serum monoclonal protein higher than 70. The other 2 were not statistically significant at the multivariate analysis, so we decided that to remove them from our score, in which we are using these 5 characteristics to construct 3 different risk groups. A low risk group with none of these characteristics, or 1 except it was the age. The second group, the intermediate group, with the age more than 65, or 2 of these poor prognostic characteristics, and the high-risk group with more than 2 of these characteristics of poor prognosis. And the evolution of these 3 groups of patients is quite different. So the low-risk group has a survival longer than 12 years, the intermediate group around 8 years, and the high-risk group around 4 years. And this is very important for us for informing correctly the patient, and also for trying to design the better therapeutic strategy for the patients, more intensive in case of poor risk. And I also said that patients without symptoms have not to be treated. And in 2003, the group in that meeting, like this one in Greece, again agreed 13 symptoms or signs that are cause for a treatment. So if the patient has one of these 13 symptoms listed here, has to be treated. The presence of B symptoms that I remember, recurrent fever, night sweats, and weight loss, and we have also added fatigue as a cause for treatment initiation, hyperviscosity, lymphadenopathy with because if the lymphadenopathy causes problems or if it is too big, in principle 5 centimeters, although the follicular lymphoma group requires 7. Symptomatic hepatomegaly or splenomegaly, other organomegalies, or any tissue infiltration causing some problems, even in the skin or in any other tissue. The presence of peripheral neuropathy related to Waldenström's macroglobulinemia. This is one of the most difficult situations that we have for deciding the therapy. Symptomatic cryoglobulinemia or cold agglutininemia. Immunohemolytic anemia or thrombocytopenia due to immune problems, nephropathy, amyloidosis, and the two more frequent that are hemoglobin below 10. In this case, the cutoff is different to the prognostic value. This case is for treatment, not for prognostic evaluation, is relatively low, below 10. And platelet count below 100,000 per millimeter cubic. All these are cause of therapy, and maybe some of you is thinking, okay, I don't have any one of them, but I have a very big monoclonal component, and my physician is very worried about it. So at this moment, the consensus is that the amount of monoclonal component only is not a cause for therapy at this moment. Even despite some clinical trials accept that, let's say, more than 50 grams per liter is a cause for initiation treatment in the clinical trial. Globally, outside of a clinical trial, I insist, the monoclonal component alone is not a cause for therapy. Maybe we can try to distinguish some patients that could be on high risk of therapy despite they are asymptomatic. This is a study that we did in 2001, and as you can see, patients asymptomatic require therapy. Some of them the median is 5 years, but some of them at 6 years, 20% of the patients did not receive any therapy. So it's possible to be without symptoms despite to have high monoclonal component. All these patients have more than 30 grams per liter in that moment, and many of them did not receive treatment. So we tried to evaluate who of them were on a high risk of receiving therapy, and those patients with low hemoglobin, in this case not very low, below 12.5, and those with beta-2 microglobulin elevated have a high risk of receiving therapy. 80% of the patients received therapy in less than 1 year. So these patients could be sometimes considered for therapy despite they are asymptomatic, but at this moment we prefer to wait. So I always finish with this slide because this is my recognition to this guy, to Waldenstrom, to Jan Waldenstrom, that was the person that defined this disease and the reason of why we are here today. And thank you very much for your attention.